I go into fluoroscopy, few concepts about fluoroscopy which I always have gathered over the period of time. Slide, can I have the slides please? Okay, in fluoroscopy, I just want you can have my presentation, so what I would like you to just sit, listen and understand this part. So what basically we are trying to do in fluoroscopy is, we are trying to convert a three-dimensional structure into a two-dimensional structure. That is point one. Second thing is that the image that we are getting is a compound image. What I mean by compound image is, one structure will overlap another structure to give rise to a third structure. So for example, this is specifically true with when it comes down to spine, is that for example there is no Scotty dog like that. So how do we get that Scotty dog? Because there are overlapping structures one behind the other, which gives rise to a structure resembling a dog. So again, three dimension into two. Second, converting one structure overlapping another structure, giving rise to a third structure. So that is why we get compound images. Third thing is structures which will have multiple structures behind them will be more readily opaque. This is common. Therefore, when it comes down to spine, there are two structures which will be most radio-opaque. That would be the pedicle and the spinous process. You may or may not be able to see the dog, but in any bad spine also, you will be able to appreciate these two structures, pedicle and spinous process. So therefore, what I will suggest, especially people who are starting off, that try to concentrate and figure out the pedicle and the spinous process, and most of the interventions of the spine you will be able to do. And that is one. Second thing is, since we are converting a three-dimension into a two-dimension, therefore we need to confirm the middle position in two images. For example, if I'm trying to touch my tip of the nose from people standing there, sitting there, they will say yes, I am able to touch it, but doctor sitting here will say no, there is a gap. Therefore, minimum two or even more, always try to confirm in that. So for example, if I'm touching my nose, whether I'm touching like this here, up, down, all the images will show that I'm there. So therefore, do not be in a rush, confirm it two or multiple images. Third, now these are the golden words of my teacher, Dr. Dhruv sir. He said, putting in a needle is not the final thing, getting a good dye spread is the key. So wherever there is the dye, there is going to be drug. So getting beautiful needle positions is not fun. Getting the good, perfect dye position is what we are looking for. With that background, let us start about the images. Now, there are three basic images. What we are trying to say is, one is AP, one is lateral, another is oblique. Now, the Siam position or the table position will not decide the AP. Right? So this is a common argument that I have with my technician who said, sir, zero to aa raha hai. Because zero nahi aa raha hai. It doesn't cater, because again there is obesity, positioning, skeletal deformities and a lot of other things. So what we take is, how do we get an AP is, we take a structure bang in the middle of the spine, which is the spinous process. And then we take structures which are on the lateral surface at an equidistance, which are the facets or the pedicle. So the spine has to be equidistant to the pedicle on both the sides. That is one. Second thing is, see, when we always imagine that fluoroscopy is like our eyes, right? And you need to align the fluoroscope in the direction where you want to put it. So for example, if you have a spine, your lumbar foraminals are in the lateral direction, something like this. So what you will need to do is, you will need to put your C-arm in this position so that you are right in the center. Versus if you want to do a trigeminal, so you want it in a foraminal. So what is the direction of the foraminal? The patient is lying supine. Patient's foraminal is here. So patient's head is here, leg is there. So what we will be doing is, we will be putting the CM position like this. So it has to be aligned. So one is AP, another is oblique. What is technically oblique is basically any position which is not the standard AP lateral or axial or coronal cuts is referred to as oblique. Third thing Dr. Tandon beautifully talked about is the parallax. Don't try to remove the parallax of the entire spine. Concentrate on the level where you are doing an intervention. Because what I have seen people struggling, they try to square the entire thing. That's not possible. Take your time, square it, find a sweet spot, and only concentrate on the level that you are trying to achieve. Okay, now counting we have counted. So what is the best way of counting? Top to bottom, bottom to top? Bottom to top. Hand, can I have bottom to top? Very good. The ideal way is top to bottom. The reason being, there is more of transitional vertebrae present as an anatomical anomaly as we know, right? Therefore, try to go initially, always try to go from top to bottom. That is one. Second thing, how I have bridged it is, how I do it is, rather when I'm looking at the MRI, rather than putting the numbers, I see whether the last disc is the problem or the penultimate disc is the problem. So I just take that equation out of it. Oblique, again, there is nothing as a perfect oblique. 15 to 25 is the literature, but try to get an oblique where your transverse process goes within the body and your facets are at 6 o'clock position. Squaring we have discussed. So this is a lumbar spine and this is a famous Scotty dog. Not a big fan, but yeah, where you get the images. Now this is an oblique image where you can see the entire Scotty dog. So this is the pedicle. Below the pedicle is the position of your foramen. So any transforaminal, whichever route you want to go. So below the pedicle is the site for a foraminal injection. Pedicle above and medial is the site for facet joint injection. And this is the site for median branch, and you need to keep the active tip in this particular direction for the median nerve RFA. So these are the various images which we talk about. Again, this is an AP or an oblique image? Oblique. You see the Scotty dog. Now here you see my target, I can only target this point because this is the part which has been squared. So pedicle, below the pedicle foramen, pedicle above and medially, this slit is the facet. So these are multiple images. The same principle is applied when we are going for a lateral image, and as I told you, we need to be very sure of our needle both in AP lateral images before we find out. The spine, I think Dr. Dhruv sir will be talking about it, so I won't. But here what we are looking for is trying to get that perfect lateral image. Here the challenge is get to perfect lateral image. Again, how do we make sure it is that like this articular pillars are like a single line. So this is a perfect lateral image, and probably during our live demonstration we will be demonstrating how do we get it. Dye, always use a dye, use a cardiac dye, do not use a urological dye. Whenever in doubt, you might be performing across the world, whenever in doubt, though it's a very standard company, but still always ask for a cardiac dye. So now just to end, this is an oblique image. This is the Scotty dog. This is the superior articular process. The eye of the Scotty dog, which is the site for the median nerve, is again the lower Scotty dog median nerve, superior articular process. This is the facet joint. This is the site for your transforaminals. So even if you cannot see the Scotty dog, most prominent structure below the pedicle is your foramen. This is the site for your discal procedures. Dog, facet. Thank you. Any questions?